Good afternoon, everyone. We will go ahead and call to order the statewide substance use response working groups, treatment and recovery subcommittee. Again, great to see everyone. Our first item of business is to do a roll call to establish quorum. So I will turn it back to Kelly Marshall.
All right. Thank you, Kelly Marshall, for the record. Please indicate you are present by stating aye or present. Assembly Member Golding.
Aye.
Chelsea Cheatham.
Aye.
Dr. Dixon.
Aye.
Stacy Lance. Jeffrey Iverson. Giuseppe Mandel. Steve Shell.
Aye.
Mr. Chair, we have a quorum.
Okay, thank you so much, Kelly. We can now proceed with today's agenda. The next item on our agenda is public comment. This is for discussion only. Public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant
Me so
to
bad. That's what
NRS
even she sent me like her dream cars, and I'm like, why?
Okay. Thank you for muting. So anyway, which action may be taken pursuant to NRS 241.2020. So on that note, I'll turn it back to Kelly with some instructions for making public comment.
Thank you, Mr. Chair. Kelly Marshall for the record. If you're a member of the public and you're dialing in from a telephone, please dial 253-205-0468. And when prompted, enter the meeting ID, which is 8948937528. You can press *6 so the host can prompt to unmute you should you wish to make public comment. So, Mr. Chair, at this point, I do not see any hands raised for public comment.
Okay, thank you, Kelly. That will conclude item number 2, which was public comment. Moving on to item number 3, this is a review and approval of our minutes from our subcommittee meeting held on June 17th, 2025. This is for possible action. Hopefully all of our subcommittee members have had a chance to review the minutes. I did want to make one notation, Kelly, before we open it up to a possible motion. In section number 7 under public comment, I noticed that the date for the Southern Nevada Substance Misuse and Opioid Prevention Summit says Thursday, August 19th, and I believe that's supposed to be the 21st. Just wanted to note that. That's the only thing I noted, so.
We will correct that. Thank you, Kelly Marshall.
Thank you. So on that note, we can entertain a motion to approve with that correction, unless anyone else has any other corrections to propose.
I so move.
Thank you, Assemblymember Golding. Do we have a second?
Dr. Dixon, I'll approve.
Thank you, Dr. Dixon. Do we have any discussion regarding our minutes from June 17th? Hearing none, all those in favor of approving the minutes, please say aye.
Aye.
Aye. Any opposed? Great. Motion carries unanimously. Thank you. Okay, so moving on to item number 4 on our agenda. This is for possible action. This is discussion related to proposed recommendations in our July presentation that hopefully a lot of our subcommittee members were able to hear. That was Mr. Hamilton from the state of Connecticut that did a really great presentation. But just to refresh everyone's memory about the proposal that the recommendation that the presentation was regarding, this was submitted by Chelsea Cheatham. And the recommendation is a retrospective assessment and a prospective study would be conducted to assess the outcomes of patients following discharge from detoxification and examine mortality and overdose. And we're very glad that Chelsea's with us today. I know, Chelsea, you weren't able to be at our July meeting. And so we were I'm very glad that you could be here today just to give us some more insight to your recommendation, but also to discuss some of the things that Mr. Hamilton raised during his presentation. So in this slide, you'll see some of the recommendations that came out of Mr. Hamilton's presentation that we can all certainly discuss as a subcommittee today. We can determine whether to vet some of these additional recommendations, or we can certainly table them for a future meeting. I did want to note and remind all of our subcommittee members that our recommendations as a subcommittee are now due by August of 2026. So we certainly have a little bit of time to consider and vet any recommendations that are brought forward for consideration. So on that note, let's look at item number 1. This is one of the recommendations raised or brought forward by Mr. Hamilton, to have the Division of Public and Behavioral Health in the state of Nevada adopt harm reduction principles in their drug treatment programs. And Kelly, I don't know if you want to jump to you've got some subsequent slides regarding this item that I think are very helpful for everyone to see. If you want to take us through those, Kelly.
Absolutely. So Kelly Marshall, for the record, just to note that when Mr. Hamilton was presenting, he was noting the things that Connecticut recommended and the council that he was a member of had recommended to the state. So if you reference the minutes that you just approved, there is a detailed description of his presentation that I think can act as a guide for how we extracted potential recommendations. So he did not verbatim say have the Division of Public and Behavioral Health and the state of Nevada, but he talked about a similar recommendation in Connecticut. So we were trying to leverage that. He also talked about them requiring implementation of informed consent at state-funded treatment programs that offer withdrawal management. So in some cases it was discussed as detox, but he said that really the preferred language is withdrawal management, and that informed consent, which we have some examples that he provided, would be to discuss the risks, benefits, and offer access to methadone, buprenorphine, or naltrexone, and to provide naloxone upon discharge, which is also considered an evidence-based or best practice. So I just wanted to note those. He also noted promoting or requiring engagement or outreach specialist recovery coaches in treatment programs that offer withdrawal management. And then the recommendation that I think is most akin to what Ms. Cheatham suggested was to fund a study to assess the outcomes of patients following discharge from withdrawal management services, to examine mortality and overdose for programs who are implementing harm reduction into treatment versus programs that do not include principles of harm reduction, informed consent for MOUD, and or recovery coaches. So in essence, the study that he was referencing, which we also provided, and I have a copy of, so we could pull up that study, but he referenced a study that had been done that indicated that in some cases, in many cases, it is more dangerous for somebody to initiate detox without access to the 3 recommendations he suggested, as mortality rates are actually higher than if they had not detoxed at all. And so one variation of Ms. Cheatham's recommendation is to actually pilot the recommendations, right, and study the difference in outcomes for those who enter withdrawal management programs, who receive the array of evidence-based practices versus those that don't. However, I think from a social scientist perspective, people would say if there is already a study out that indicates increased mortality an overdose by not providing those services, then doing a comparison of programs that would offer services versus would not could be considered dangerous and unethical. So wanted to note all of that. And I would just continue to refer people back to either the presentation or the minutes that you just approved, because I think the description of everything I just went over on these slides is, the slides are a summary of that description. So in terms of that potential recommendation that he suggested around adopting principles of harm reduction, I think you can see from this slide what Mr. Hamilton provided was the principles are engagement, philosophy of readiness, common program models, and then he compares abstinence-based recovery with harm reduction. His suggestion is that programs be asked to adopt principles of harm reduction, i.e., welcome individuals regardless of whether they're ready or willing to stop using, meet people where they are and support any positive change, engage in models that include needle exchange, medication for opioid use disorder or MOUD, overdose prevention and housing first models, and then the principle of a definition of success that includes reduced risk and negative consequences associated with substance use, including continued use as opposed to complete abstinence or cessation. That the primary goal be improving health, safety, and well-being regardless of ongoing substance use versus lifelong sobriety, and that the principle of the approach to use is that substance use is seen as on a spectrum and the focus is on reducing harm rather than eliminating use, versus substance use seen as inherently problematic and to be stopped entirely for the definition of success to be reached. So those attached to that recommendation of adopting principles of harm reduction in treatment programs. In terms of informed consent, the example he provided for informed consent was to explicitly make it known in treatment programs that medications for opioid disorders are available and considered the gold standard of treatment, and that it's an evidence-based treatment for individuals with an opioid use disorder. And that while counseling and behavioral therapies are an important part of treatment alongside medications, medications alone are effective, and medications are also used to relieve cravings, withdrawal symptoms, and block the euphoric effects of opioids. The medications don't cure the disorder, but improve safety and prevent withdrawal symptoms, which in turn can lead to relapse and continued substance use. So the second part of that informed consent, and this is referring to specific programs in Connecticut. So that's what the reference to liberation programs is. But that a program, in this case, the recommendation is that treatment programs offer the following medications and suggest anyone with an opiate use disorder receive one of the approved medications. So methadone, buprenorphine, or naltrexone. And then there's a description of what those medications do. And the third part of that informed consent is that all clients discharged from a treatment program would receive Narcan or naloxone. Actually, naloxone as a life-saving medication used to quickly reverse an opioid overdose. And the informed consent is really asking that all clients or patients indicate that they've been educated on the risks and benefits of taking or refusing MOUD, and they either accept or refuse. So not mandating, but ensuring that there is informed consent. And then the third piece related to the study, this study was actually the version that we were able to pull and provide from his citation was published in 2024. And it's receipt of opioid use disorder treatments prior to fatal overdoses in comparison to no treatment. And we actually have, excuse me, that study here. And so it's co-authored by the Yale School of Public Health, the Yale School of Medicine, the University of Connecticut School of Social Work, and the VA Connecticut Healthcare System. And as we mentioned, this was published in Drug and Alcohol Dependency, January 01, 2024's. I think periodical journal. So we have that there. So I think that's all of the background. And Steve, Mr. Chair, I hope that lengthy response and walk through those slides was helpful. And then we can, I think, turn it over to Chelsea for discussion, Ms. Cheatham for discussion.
No, thank you, Kelly. That was extremely helpful for me. I'm sure it was for the rest of our subcommittee members. I did want to call on Chelsea if she's, not to put her on the spot, but if Chelsea would like to give us some insight into her recommendation. And I think Chelsea's probably very familiar with what they've done in Connecticut. So I, like some of our subcommittee members, are probably very interested in hearing more from Chelsea on this. So Chelsea, if you don't mind me turning it over to you.
I don't, thank you. And thank you, Kelly, for giving that background information about the presentation because I was unable to be at that meeting. So yeah, I appreciate the suggestions for further recommendations that were made at that meeting. I had made my recommendation really solely based on looking at this as a retrospective study because this Connecticut study had shown that there is a significant reduction in opioid deaths after people are exposed to methadone or buprenorphine. It just seemed like we could just look at this retrospectively and then we could create recommendations in the future based on the study. And I'm unsure exactly how we could do it because I don't know all of the agencies and groups that we're going to have to bring together to be able to collect this information on individuals who have exited treatment and also comparing that to whether they were exposed to MOUD and then following them for a certain amount of time to see what happens in the future. But if the group wants to maybe weigh in on ideas related to my suggestion, the other suggestions, I'd be happy to hear them. But I'm looking at this as more of a retrospective study since we know that there's such a large reduction in death already from what they found in Connecticut.
Chelsea, what are your thoughts that, since the state of Connecticut, well, since Mr. Hamilton has conducted this study in Connecticut and has some great data, do you feel strongly that because there is already data out there that we still need to look or drill down on our own data within the state of Nevada?
I do, because I always say that it would be easier for us to recommend this to treatment agencies or facilities that are providing detox if we can show that there's a reduction in death here in Nevada. And also we're going to have a more recent study. I believe this study was done in 2017 is when they were looking at the deaths. So if we can show a more recent study and show that this is similar to what we're seeing in Nevada at this time, I think that it would make for a stronger recommendation.
I think that's a very good point, Chelsea. I know as you probably already thought about, Connecticut and Nevada are so different. I know Connecticut is historically in like the top 10 or top 15 of the states in the nation, when it comes to access to treatment and a lower prevalence of mental illness and substance use issues. So I'm with you. I think it would be interesting to drill down on our own state. I just wanted to put that out there for our subcommittee and see how the rest of our members feel about, continuing this discussion or potentially making this a recommendation to the SURG.
Mhm. Yes, and you're right, Chair Shell. Even the drug supply, especially on the East Coast, is often different than we see here in Nevada. So I think it would be very important for us to look at this in Nevada specifically.
Yeah, I agree, Chelsea. Thank you. I wanted to open it up to the rest of our members on the subcommittee and just see if anyone has any thoughts or questions for Chelsea.
I have a question.
Yes, Assembly Member.
So I'm looking forward to getting a copy of the study. I don't think it was included in the packet for today, was it?
Yes, it was in your
Okay,
packet,
it's in there.
yes.
Thank you. So one of my questions is really even on working with the assumption that the presentation was really fabulous last time. The results seem super promising. Nonetheless, the question that comes to mind is there any other data? Are there any other studies that either substantiate those findings or challenge those findings? Because it is only one study, and I think it's important that we make sure that we're not looking at just one data point, as it were, even though that it's an aggregate data point. So that would be one question that I have. Absolutely. So originally it seemed like the recommendation was to have to start a study. And I think that you've all put it very well that if there's data that's establishing that this is the best practice, then yes, let's go forward with that and collect data at the same time. So it shouldn't necessarily be an either or, but an and. So moving forward and also collecting data to make sure that what's happening in Nevada is also outputting that same good results. And then finally, I think that there's a public education element that goes along with this, because that's a pretty, the shift or the difference between these two different perspectives is pretty big. And I think that a public information or some training to folks on these two different perspectives, so that there is an understanding that the harm reduction versus abstinence based is there's a reason for that, because there certainly will be a lot of people that will question and feel very uncomfortable with that. And so I think that it has to go along with education, not just here amongst this subcommittee and not just amongst the SURG, but amongst a broader population.
Excellent points you're making, Assemblymember Golding. I wanted to turn it back to Chelsea to address your questions, if you don't mind, Chelsea. And then I just wanted to mention quickly, Chelsea, to bring up SAMHSA and see if there's any data, national data coming out of SAMHSA that you're aware of. So Chelsea, if you don't mind me turning it over to you.
No, yes. So I was able to find another study that was done in Massachusetts, and this study was looking at also retrospective data between 2012 and 2014, and they found really similar outcomes. So there are some other studies. I can do some research and pull some of that information, and I could send it to Kelly as well to send out to the group. And then Chair Shell, I think that's a good idea to look at SAMHSA and see if they've done some research on this as well. And I can take that on and find some additional information for the group.
Okay, that would be great, Chelsea. And then regarding Assemblymember Golding's point about public education, do you have any thoughts around that, Chelsea?
Yes, and as the person who's representing harm reduction and someone who loves harm reduction, I know that a lot of times there needs to be education on, the need to meet people where they are, because not everybody is looking to get into treatment, looking to stay abstinent. So I know it's important to meet people where they are, and I did appreciate those further recommendations. But I think, you know, in the just kind of in the interim, if we could possibly just look at this study first, and then maybe use the study and the information that we get from Nevada to really further those additional recommendations, that might be helpful. And to really figure out, you know, what type of education we may need to do, you know, broadly within our state on meeting people where they are. And then also, you know, I'm looking at MOUD as like treatment and not really harm reduction, as it seems that the further recommendations were kind of framing it. So I think looking at MOUD as treatment and post detox treatment may help to make this education a little bit easier.
Yeah, thank you so much, Chelsea. Assemblymember Golding, did that answer all of your questions, or is there anything else for further discussion?
Yes, thanks. I appreciate that. And I appreciate that I'm brand new to this committee. So when I'm asking, please know that it's from a state of, you know, really trying to understand and develop better understanding, building context and all that. There was one thing on the list that I thought I wished was on your chart when looking at the difference between harm reduction and abstinence. And one of the goals of harm reduction, meeting people where they are, I wanted to see included on that chart, keeping people alive as a base goal. And I'm trying to remember, as you're flipping through here, I'm trying to identify where I saw that. And it may be this, like one of these in this primary goal, because improved health, safety, and I think that there's this is really coupled with the notion of public education, is harm reduction means keeping people alive, like as a very base level that I think is important to express.
No, I think that would be an excellent addition, Assemblymember Golding.
Mr.
Kelly,
Chair, Dr.
yes, go ahead,
Dixon-
Kelly.
Dr. Dixon has her hand raised.
Oh, I'm sorry. Yes, Dr. Dixon, I'll turn it over to you.
Yeah, it's Dr. Dixon for the record. Well, I like the idea of doing studies. Having done studies myself and working in the field, it's hard to do. These people, someone has to do the follow-up, and that requires hiring researchers and to make phone calls and search records. Some of the best studies are done by places like, and I don't really know, I didn't look at the details of the study we're talking about, but some of the best studies of things like this are done by large groups like Kaiser and places like that, which have kind of a population that's stable and kind of rounded up. And for us, which is the problem with mental health in general in Nevada, is we just have tons of silos, but not too much interaction. And so it's unfortunate that Jeffrey Iverson is not with us, because his place, Crossroads, is by far the most utilized detox facility down here in the South. And I don't know if they're doing a lot of studies. I know that they've had some change in the medical staffing, and I think they're getting a little bit more proactive in referring people to treatment. They didn't, for MOUD, they didn't used to do that. They used to send them out without any referrals. And for MOUD anyway, that it's getting better. I'm starting to see patients that are coming from Crossroads. And the drug courts are really helpful in referring now. some of the problems is the population itself is kind of like Las Vegas in general, is it's transient, and you may have an address and a phone number one day, and neither one is any good the next. And so, how do you do follow up? And so there's so many practical aspects of doing studies like this, and not to mention that substance use individuals are highly protected by the law, by HIPAA and some of the other laws. And so, you can't just, I'm not sure you really can just make a phone call, and because you never know who you're going to get and what you're going to get in terms of the person. So there's a lot of practical issues. And but I'm saying, I think something like Kaiser or one of the large groups that manages patients, but I don't know, like here in Las Vegas, some of the really large insurance-based groups like Optum and stuff like that, I don't even know if they're treating patients for substance abuse at all. I've never seen a patient come from a place like that. And I don't know that they have anybody on their staff that's addiction oriented. So it's, that's because I'm used to thinking of all the problems you're going to have with doing studies. But one of the things I want to talk about, because I was talking with John Firestone yesterday from NODA, and we would like to do a lot more getting people aware of treatment and getting them into treatment. And I think somehow maybe we're going to have to do public service announcements and stuff like that to get the word out. Anyway, those are my thoughts.
Thank you, Dr. Dixon. And your last point certainly speaks to what Assemblymember Golding was bringing up about, the public health aspect, public education aspect. So, Dr. Dixon, based on what you just raised, I wanted to turn it back to Chelsea and just see if she had any thoughts as to how the study would be coordinated. Chelsea, if you've given any thought to that yet.
Well, I haven't really, well, I've given thought to it. I don't know. I know the information is out there because this study has been done in multiple states. And because it's retrospective, I'm guessing what they're looking at is, not doing follow-up with patients, but, just looking at other documentation that's readily available, maybe hospital records or death records compared to, medical records. But I don't know how to get access to all of these things and how they put it all together. So I think that might be something that if we are interested in this recommendation, maybe we could find one of the researchers from one of the studies who's done this before and maybe just find out how they did it, and what documentation they got and how they were able to get access to everything.
Yeah, that's a great idea, Chelsea. If you could help us identify someone that we could invite to a future meeting, that would be great.
I will do some research and I will try to find someone.
Thank you, Chelsea. So regarding item number 4 on our agenda, this was for possible action. We could certainly entertain a motion to move this recommendation forward, or we can all agree to continue vetting this recommendation and have the presentation that Chelsea just mentioned, along with sharing some possible data from other states, as well as nationally through SAMHSA. I would recommend that we look at the latter and continue to vet this with Chelsea and others, but we can certainly entertain a motion if anyone is so inclined. Do any of our subcommittee members have thoughts around that? Yes, Assemblymember Golding, I'll turn it over to you.
I think that I like the idea of working a little bit more before we solidify a recommendation, and I think we're going in the right direction. As a newbie, I certainly appreciate all other input but I think that I personally think that we're on the right path, but a little bit more work before we solidify something would be beneficial.
Okay, thank you, Assemblymember Golding. Do we have anyone on our committees opposed to that? Okay, so it sounds like we will keep this as an agenda item on our hopefully our next meeting if we have some presenters lined up. So Kelly and the SEI team can explore that for us. Any other discussion points regarding item number 4 before we conclude that item? Okay, we will conclude item number 4 on the agenda and move on to item number 5. This is also for possible action. Just to remind our subcommittee members that last year, our subcommittee brought forward 4 recommendations to the full SURG. And as a subcommittee, we certainly have the option of bringing those recommendations forward again by August of 2026. We can certainly look at our previous recommendations and make any changes to those, or we can submit, new recommendations. So we just wanted to go through again the 4 recommendations that were submitted last year and just see if that prompts any discussion or any ideas. You'll see there the first recommendation that was brought forward last year. I'll just read this quickly. Legislation should be considered to amend the Nevada revised statutes pertaining to the Nevada Bureau of Healthcare Quality and Compliance's employment guidelines for hospitals, including behavioral health hospitals, to hire certified peer recovery support specialists who have felony backgrounds and are within 3 years of their last felony conviction. It is recommended that individuals who were convicted of drug offenses or other offenses that do not involve violent acts or sexual exploitation be considered for employment as certified peer recovery support specialists in hospitals. This is a recommendation that I made forward last year, that I made last year that our subcommittee then decided to move forward to the full SURG. I personally still feel strongly about this one. I haven't seen any action taken place around this one, so I hope that our subcommittee will agree that we can keep this as part of our discussion for this next year. I do want to note that the Bureau of Healthcare Quality and Compliance has now moved under the new Nevada Health Authority. So I think it would be interesting to eventually bring someone in from the Nevada Health Authority to speak to us, as we might want to consider, moving this recommendation again. Just for Assemblymember Golding to know, the current NRS requires someone with a felony within the last 5 years be excluded from being hired by a hospital. And we had felt strongly that that was eliminating a lot of individuals throughout our state during a time when we're trying to build up our pool of peer recovery support specialists. So our recommendation was to make that within 3 years of their last felony conviction. I don't know if there's any discussion or any I see Dr. Dixon with her hand raised. Yes, Dr. Dixon.
Yeah, so thinking about this, as Dr. Dixon, did we reach out to anybody about having a bill? This turned into a bill? Did that happen?
I don't believe so, Dr. Dixon. There were so many bills, so many ideas for bills that I think this one may have been overlooked, but I would love to keep it on our radar for the coming year and before the next session. But I think that's a good point. No, I don't think it was taken on by anyone as a BDR, from my knowledge.
So I think that would be the thing we want to do that. And the other is, when I was working years ago on a bill, we really, really wanted it, and it took 3 legislative sessions to get it through, was to have all the people that would be affected and maybe opposed talk with us. And so this looks like one that we need to talk, besides what you were mentioning with state, is the hospitals, and see where they are, both on this part and peer recovery altogether, because part of the problem is getting peer recovery support specialists paid and in these environments, regardless of what their background is. And so I think we need to really explore these ideas with some people that actually would be opposed if this bill were to just pop up.
Yeah, very good point, Dr. Dixon. And you just helped me jog my memory that I think we should definitely talk to the Nevada Hospital Association, since they represent all the hospitals in the state, both med-surg and behavioral health hospitals, as I think you bring up a good point. There could certainly be opposition from the hospitals on this. I'm just speaking on it from my background running hospitals in the state, but there could be others in the state, they're certainly opposed to this, and others that are for it that we're not even aware of.
Yeah,
I see a similar. Oh, yes, Dr. Dixon.
I would suggest that you see if Patrick Kelly could, he's the head of the hospital association. If he could, and he lobbies too, if he could come talk with us maybe about peer support in general, and what's it going to take to really make this happen, because they're the ones that do the emergent that we kind of want, and some hospitals already do the ER patients and try to, but not very many, because they don't have a way to get paid.
Right.
So.
Good point. Any other discussion regarding this one before we move on to number 2? Okay, so the second recommendation we moved forward last year to the SURG, which I will note eventually became a bill and was actually passed by the legislature and signed by Governor Lombardo. The recommendation was to support BDR 95 to ensure opioid antagonists must be available on all campuses under the Nevada System for Higher Education, including in student unions, health centers, all levels of the dormitories, residential advisors' domiciles, sports facilities, and libraries, and include training of the administration of opioid antagonists, which can take place during online freshman orientations, much like we already disseminate information about Title IX during orientation week. Training could be offered throughout the year by various clubs and programs within each institution's design. So I think we were all proud to see that one move forward. I can't remember when it was actually signed, Kelly, unless you may remember.
I would defer to Laura Hale, who has been our tracker. Kelly
Yes.
Marshall.
Oh, yes.
I'll take
Thank
a look
you.
for that and get back with you momentarily.
Thank you, Laura. I know it was in your last presentation, Laura, and I just can't remember the date, but that's okay. Thank you.
You're
But
welcome.
just wanted to note that that's one of the highlights of our subcommittee from last year, that actually now has moved forward and been signed by the governor. Any discussion regarding that one?
Yeah.
Yes, Dr. Dixon.
Dr. Dixon. So I have seen this, and I'm not sure all the details that are in what's written right here were put in the bill.
Yeah, I don't know. I'm not aware of that either, Dr. Dixon. I'm not sure if all of those details there actually made it into the bill. I do know it's now available on all campuses, required to be available, but I'm not sure if all those other details actually made it in.
Yeah, because someone's going to have to take the responsibility for doing this and have some money to buy this. I mean, and so it's going to take probably some grant money or something. And then the training, that's another aspect so I mean, well, a lot of BDRs have to go somewhere for regulations. Maybe that's where this is going, to a regulation, and then they will work on some of the details.
It possibly is, Dr. Dixon, and I wanted to note that we as a subcommittee still reserve the right to take portions of this recommendation and put it into a new recommendation for next year. So I think that's why we'll keep this one on our radar in case anyone sees a way we might want to vary from what the legislature just passed and which was signed by Governor Lombardo. I wanted to defer to Laura while she's checking on that date before our next meeting, if you could also look, Laura, to see if all of these details were actually covered in the legislation.
Yeah, so the governor approved that on June 5th, and it was effective upon approval. And my summary notes, let's see, bill requires such an emergency response plan to include plans for providing education on opioid-related drug overdoses and procedures for the distribution and administration of opioid antagonists. There was an amendment that changed the dosage from 4 milligrams to the lowest effective dosage, prohibits disciplinary action for obtaining opioid antagonists. And yeah, the recommendation to ensure opioid antagonists must be available on all campuses with training provided for administration. That's all I have in my notes here, but I can go back if there's more detail to give you at a later time.
Thank you so much, Lori. Yeah, I'm not sure if the bill actually specified all those different locations on each campus, like student
Oh.
unions, health centers.
Well, on all campuses with train must be available on all campuses. So I would think the whole NSHE system.
So yeah, so the question is this going over to NSHE to implement, or is there,
I'm sure it will. I mean, there were people at NSHE who were engaged with putting that forward. So we can reach out to them and find out.
yeah, I think that's the thing to do, is to find out from NSHE where they're going with this.
Okay.
That would be great to know. So thank you for bringing that up, Dr. Dixon, and thank you for following up, Laura.
Sure.
Any other discussion regarding number 2? Okay, moving on to the third recommendation that we have moved forward last year. This was submitted by Chelsea Cheatham. This was to support access and linkage for the treatment of trauma for people with substance use disorder or those who have overdosed, and for surviving family members after an overdose fatality, and to support training for healthcare professionals to identify and address trauma. I don't believe this one made it to a BDR either. Chelsea, I don't know if you have any more information for us on this one.
I don't believe it made it to a BDR, but I don't have any other information on it.
Okay, thank you, Chelsea. So again, going back to what I said a few minutes ago, this is certainly a recommendation we could decide to move forward again for 2026. We could make some edits to this and then vote to move that forward. So we do have some options on that. We just, again, wanted to keep this on everyone's radar today. Any other discussion regarding number 3?
Chair Shell?
Yes, Laura.
Just with regard to the BDR question, so the recommendations, go forward to the legislature, and they go forward to DHHS and to the governor, but rarely does the SURG put forward to say, we would like, X body to make a BDR. And so there's nothing, magical about the BDR process that just by having a recommendation is going to achieve that result unless, and so we are working with DHHS on some of the process stuff, and they will be coming to the SURG in October to present at that time, both in terms of updates on progress that they've made on some of the recommendations that went to DHHS. And now, the split off group as well, where Medicaid is residing along with HEQC. But, we are also asking them to help us with the process on some of this stuff, because, like I said, there's nothing, part of it is a timing issue for when our recommendations go forward and when BDRs are due from different, whether it's a state agency or whether it's a legislator. So I think some of this is educating everybody about the process and maybe fine tuning when you are expecting that a bill draft would come out of a recommendation, that there's a little more targeted effort on that. That makes sense.
No, that makes a lot of sense, Laura, and I appreciate you bringing all of that up. I think we all do need to remember that a recommendation doesn't necessarily mean that it's going to become a BDR. As you said, Laura, there's lots of pieces that go into that. So thank you. I see Assemblymember Golding with her hand raised.
Have you in the past worked along with the interim HHS committee? So this seems like it would be a good marriage of, doing the SURG, doing some front work, and then working with the interim committee, because that's then a segue into a BDR. So I guess
I
the
would have to
question is,
defer to Kelly and Laura on that. Laura?
Yeah, because there are SURG members who are legislators like yourself, including Senator Doñate. I think there has been an awareness of recommendations that go forward, but not necessarily make the cut. I mean, everybody's limited, and Dr. Kearns, I see, has her hand raised. She could probably answer better.
Yes, Dr. Kearns, hello.
Hi, yeah, I just wanted to highlight that Senator Doñate did request that the Attorney General's office do a presentation to the interim health committee, and we did provide our recommendations to them and for their consideration to move forward with any BDRs or to provide support for those recommendations. So we have worked with them in the past and do hope to continue to work with them in the future.
Thank you, Dr. Kearns. Dr. Dixon?
Okay, so what happens when you send stuff like this to the legislature or to legislators is they turn it into mandates for CME and CEUs. And and it's gotten, for all of us medical people, it's gotten totally out of control, all the mandates. And I think they may have gotten, and they tried a bill that didn't pass to try to get that more under control. So when you say support training for healthcare professionals to identify, I mean, obviously a healthcare professional should know how to do this and should be able to do ACEs and things like that. But whether they do or don't, I don't know. But I would like to have a little bit more in this recommendation of exactly what support means. I mean, for instance, residency training, we have what's called the Green Book, and all residencies are defined in the Green Book, and they tell exactly what for each specialty, exactly what a resident needs to do and learn in their training. That we can for psychiatry, obviously this should be in there, and I assume it is. But just saying we support it is like a statement, and how to implement this is, like I say, is liable to end up with another CME mandate, which should make everybody very angry right now.
So on that note, Dr. Dixon, great point you're bringing up. We, as a subcommittee can certainly decide to expand on verbiage or concepts in this recommendation, or we can certainly table it and not bring it forward for 2026. So we have a lot of options as a subcommittee. So for the sake of this one, we can certainly keep this on our list and continue it continue discussing it in future meetings, unless anyone has any particular presenters that they might like to hear from. We can certainly leave that open. Yes, Dr. Dixon.
Well, one thought was, with this opioid settlement money, a lot of different entities have access to the money. And so one of the early things they did was over in Henderson, and they had a very educational oriented thing. So I would want us to bypass the legislature on this one and really try to encourage organizations or whatever to do educational meetings on trauma and how it overlaps significantly with substance abuse, and so it'd be more like you could have somebody, say like the medical society or something, whatever group, would want to talk about training and for trauma and substance abuse. And then that group could actually get the CEUs, and it'd be voluntary, because we all have to do, say like what we have to do is 40 CMEs every 2 years. About 10 of them are covered by mandates, but the other 30 we could fit in something like this. And I'm sure that's true of all the other professions too. And so I think that would be something that might be suggested to those who are putting out RFPs for the opioid money.
Yeah, then that could be certainly something that we note in this recommendation as to how we're recommending funds be directed.
Yeah.
We could certainly consider that too, Dr. Dixon. Thank you.
Uh-huh.
So item number 4 is, and I'm forgetting the name of the physician who brought this forward in a presentation last year, Kelly, unless you may
Yes.
remember.
Dr. Kelly Morgan.
That's it. Yes, Kelly Morgan. Okay. Yes, Dr. Kelly Morgan presented to our subcommittee. And as a result of that presentation, we decided to move this forward, this recommendation forward to the full SURG. So the recommendation was to direct the Division of Public and Behavioral Health to identify a funding mechanism for hospitals and providers to enhance the bridge program for emergency departments by incorporating peer recovery support specialists into their treatment models, and to support the use of peer support navigators via telehealth to increase access to treatment and support for individuals identified in emergency departments. And I think this one certainly speaks to the point Dr. Dixon made earlier about why hospitals may or may not, go down this road. A lot of it is due to the funding mechanism. I do see Dr. Dixon with her hand raised, so I'll turn it over to you.
Oh, no, I didn't. I think I forgot to lower my hand.
Oh, okay. Thanks, Dr. Dixon.
But you're right.
But-
I have already kind of spoken to this. So yes.
Yes, and a lot of it, still pertains to the funding mechanism. I see Dr. Kearns with her hand raised. I'll turn it over to her.
Thank you, Chair Shell. I just wanted to highlight that the response subcommittee also had a presentation from Dr. Kelly Morgan talking about the bridge program, but from a different aspect. And one of the things, and this kind of would go along with your recommendation number 1 as well, is that currently Foundation for Recovery is providing peer support specialists to some of the hospitals, and the funding for them currently is grant funding. I don't remember if it's from the Fund for Resilient Nevada or if it's one of the other grants out of DPBH, but that is something. And I know that Sean O'Donnell would likely be a good person to come and talk to you guys to find out the funding, but he continues to push as well to try to get a funding mechanism where peers could be reimbursed through Medicaid.
Yeah, thank you for noting that, Dr. Kearns. I know Foundation for Recovery is doing a lot of work in the state at the moment. I don't know if it's necessarily Sean. If it is, that's great. I would like to hear more about the different grants that are being used. I know during my time at Renown Health, we relied on a grant from the state, and I actually had a team of peers in the emergency room, and then Renown ended up losing the funding, or the funding just ran out. And so we no longer could afford to keep the team in place, but I know that is an issue for a lot of hospitals around the state. So I would be interested in hearing more about different funding streams, particularly with grants. Is there any discussion regarding number 4? Yes, Dr. Dixon.
Yeah, was there a bill or something related to peer support and payment? I think their Medicaid eligibility, I think they and community health workers both, wasn't there a bill about them being paid by Medicaid?
Yes, there were, and there has been progress made on that. That's another thing that I can look back and try to come back to you in a minute.
Yeah, thank you, Laura. Dr. Dixon, I do know there's been a lot of work with Medicaid around reimbursement for peer support, but I know a lot, or almost all of the commercial payers I'm aware of, are still not funding peer support specialists. So I know we've done a lot of great work in the Medicaid arena. It would be interesting to explore it with the other payers as well.
And
But
Mr.
outside of that,
Chair-
I'm not aware of any specific mechanisms being in place at the moment. Yes, Kelly.
Yeah, Mr. Chair,
Oh.
I just wanted to remind the subcommittee that they had Mr. O'Donnell come and speak to them and do a presentation specifically on peer recovery support specialists prior to that legislation being brought, or that recommendation being brought forward by this subcommittee, which was the 2023 report is where that recommendation was forwarded by Treatment and Recovery.
Yeah, thank you for that reminder, Kelly. I do remember that Sean gave us a great presentation at that time. Going back to the grants, I'm still not aware of what grant dollars are being used unless it's the FRN dollars, the Foundation for a Resilient Nevada, Fund for a Resilient Nevada, which are the opioid lawsuit settlement funds. I'm not sure if that's where some of these grants are coming from, but it'd be interesting to find out. Any other discussion regarding item number 4? So again, we can either entertain a motion to do something with each or all of these 4 recommendations, or we can certainly continue these as part of our discussions for the coming year before we make our recommendations to this full surge in August of 2026. So I would move more towards the latter of those 2, unless anybody is opposed to that. Okay, so hearing none, we will keep these 4 on our radar. And it sounds like we might have a couple of possible presentations and things to look at for those 4 recommendations. So moving on to item number 6, this is for possible action. This is to discuss and draft proposed 2025 Treatment and Recovery Subcommittee recommendations. Again, as I've been sharing, as Kelly's also reminded us, our recommendations are not necessarily due until August of 2026 rather than this fall. So we certainly have some time to vet these and come up with other ideas as well. There is one that I've already submitted that I just briefly discussed last month. And believe it or not, this is also regarding peer support. I feel very strongly about peer support. I'll just read my recommendation here. Hospital emergency rooms in Nevada continue to lack evidence-based peer support teams that can provide a vital service to their patients who present with substance misuse. Many of these patients have multiple visits to the ERs due to not being adequately connected to community services for treatment or not having ongoing support to maintain their recovery. Hospitals lack the financial resources necessary to cover the expenses for peer support teams, whose services are not reimbursed by most insurance companies. It is recommended that hospitals be incentivized through an expenditure of opioid settlement funds to establish peer support teams in the emergency rooms. And I feel strongly that that's the only way to really get hospitals around our state to consider those teams. We've had a handful of hospitals in the state that have actually implemented these teams. Some of those have not been able to continue them for, due to funding challenges. So I just wanted to bring this recommendation forward. And that's some of the background on why I brought this forward. So on the next slide. Oh, I thought there was another slide, Kelly. Was there not? Oh, sorry, Kelly. I'm jumping ahead here. So here is a little bit more background on why I brought this forward as a possible recommendation for us to consider. Hospital ERs continue to struggle with a high volume of patients who present with substance use and often with co-occurring mental health conditions. A high percentage of these individuals have multiple visits to the ERs for various reasons that are associated with their substance misuse. The ER teams do their best to evaluate, treat, and connect to community services, but many of their team members lack the expertise to effectively manage substance misuse and do not have lived experience like peer recovery support specialists. Evidence has shown that connecting individuals with substance misuse to a peer while in the emergency room leads to better outcomes, as the peer can help navigate a transfer to treatment options in the community, as well as maintain communication with the individual for a period of time to encourage recovery. Hospitals would be more motivated to establish peer support teams if financial assistance is provided on a long-term basis. So that's just a little bit more justification as to why I brought that forward. And I hope that we'll all agree to keep this on our radar. And I'm certainly open to any questions or any comments regarding this. I know we've talked a lot about peer support today. And as we shared a few minutes ago, there has been a lot of great work that has occurred around peer support. We have really made great strides in our state regarding peer support. So I definitely want to remind us all of that. But I just feel like hospitals in particular would be better served by having these teams in place if there was some sort of financial or funding mechanism in place to assist them with that, so that they don't have to make that difficult decision to not have those teams. Yes, Dr. Dixon.
So, I think a couple of problems, things that get in the way. One is, we're running into it with, in another way too, is hospitals have to have line items for, or so to speak, for different professions, right? And so I think that peer support kind of is like a stepchild or an unwanted something or other, and so they have not really built them into the hospital budget system and everything, and so yeah, I think grants are the way to go for a start, but somehow the hospitals have to come to appreciate that these kind of folks can be very helpful and should eventually end up as regular employees, and which is going to take probably some change in the way of thinking in the finance offices. Anyway, so that's what I'm thinking is we need to move that needle on this one to have them start to realize that. And the other thing that comes to mind is that within a medical setting, people like peer support and probably need a higher up level of profession kind of supervising them. And how does that work? Is that come under nursing or social work, or are they just there by themselves without any supervisors?
Well, my personal experience with the team, Dr. Dixon, is we had them reporting to nursing and the physicians. And so the peer support specialist would not meet with the patient in the emergency room unless they were directed to do so by the nurse or the physician, just to ensure that that individual needing those services truly needed that peer to come meet with them. Yeah. But that was just my personal experience. I see Chelsea Cheatham has her hand raised. Chelsea?
Yes, thanks, Chair Shell. So I know that currently the PACT Coalition has actually worked with Dr. Morgan at Valley Hospital to get peers credentialed or badged to go to the hospitals within Valley Health Systems. So if you are interested in doing any sort of presentations around this, I could set up some of the peers that are in the hospitals, as well as possibly speaking to someone at Valley Health Systems who has set this program up or is currently utilizing peers to do a presentation on this.
That's an excellent idea, Chelsea. I wasn't aware that Valley was doing that, so that's great to hear. That's a great presentation idea. Thank you. And then I wanted to note again about something Dr. Dixon brought up earlier about Pat Kelly, who's the CEO and president of the Nevada Hospital Association. It may be, Kelly, at some point appropriate to engage him too, just to get an idea from him about how he feels the hospitals are perceiving this or would perceive this. So just wanted to note that as well.
Thank you, Chair Shell. Kelly Marshall for the record. Also, Laura Hale has an update.
Oh, great. Yes, I'll turn it over to you, Laura.
Thanks, Chair Shell and Kelly. So from the reports that we did back in May to all the subcommittees, these were progress reports that came from different divisions under what was then Health and Human Services. So one was from Medicaid, that they were initiating a policy revision for peer support services and adding family peer support as an available service. Also, peer recovery support specialist is now a specific enrollment specialty. Medicaid is targeting an end-of-year SPA submission to increase reimbursement rates for behavioral health outpatient services that would include peer services. And then through the one of their bureaus. They support funding of peer support training and certification through recovery services with partners such as Foundation for Recovery. The Bureau is exploring additional opportunities to ensure those with living and lived experience are embedded in the various aspects of program development. And they also note that SAMHSA, which is the federal funder for substance use programs, they encourage organizations to involve individuals with lived experience.
Very good to know, Laura. Thank you for clarifying all of that.
You're welcome.
Any other discussions regarding this particular recommendation? It sounds like we've got a couple of possible presenters to consider for future meetings. So we can certainly keep this recommendation on our list to consider before we make our full recommendations to the SURG for next year. So that will conclude item number 6 on the agenda. Moving on to item number 7. This is for discussion only regarding upcoming presentations and topics. I know we do have a few. Kelly, I don't know if you want me to turn over to you and start with you for any that you're aware of.
Certainly. Thank you, Chair Shell. Kelly Marshall for the record. So I think we have sort of a laundry list established from today's discussion. And then I wanted to note again that there is a SurveyMonkey link. I will reissue that link to all subcommittee members after this meeting. And that is the mechanism by which you can submit recommendations. Recommendations do not need to be fully developed. If you have a recommendation and you have ideas for a speaker, you can request a presentation linked to a topic or a recommendation in that way. As you noted, Chair Shell, and as Dr. Kearns has noted in previous meetings, the calendar for SURG and its report is changing. So there will be the annual report in January. However, it will not include final recommendations. Those have been moved to an August 1 report. And that is explicitly to facilitate engagement of the legislature and our policymakers in giving them sufficient time to look at recommendations and determine if there are BDRs they want to request or policies that could be championed as a result of the recommendations being made. So we do encourage all subcommittee members to submit at least one recommendation. Last year, or for the 2024 annual report, which was published in January of 2025, we submitted 5 recommendations. That's typically or 4 recommendations, 5 is the cap. Suggested cap doesn't mean that's always the case. So our upcoming subcommittee meeting is September 16th, and then we have one on November 18th. And I think what we're specifically now looking for are presentations and the priorities of this subcommittee for those 2 meetings. And so that's what I would like to test is the direction of this subcommittee to follow up with Ms. Cheatham to see if there are folks who did the previous study, the aforementioned study related to opioids and fatalities, that if we can identify somebody and connect with them, that would happen in September and or November. And then Ms. Cheatham also offered to connect us with peers to get the lived experience perspective. And so that was a second opportunity that I heard. And I wasn't sure related to the other discussion if there is another presentation that this subcommittee would like to elevate for either September or November.
Kelly, I know Dr. Dixon has brought before Crossroads, and I know she mentioned it again today. Dr. Dixon, I don't know how strongly you feel about bringing someone in from Crossroads, but I know you've mentioned that in the last couple of meetings.
Well, I feel pretty strongly right at the now it is the what we have down here for detox and they have rehab programs, IOPs and everything for the, the patient with moderate to no resources. We've got some higher scale, people with good insurance and stuff have places to go. But Crossroads is really for the people that don't have the greatest resources. And so they got a lot of patients, and I've never really been over there. I know some of the staff, but I think we should really have somebody come and talk from Crossroads and tell us what's going on there and what we could do to help them.
So
Thank you,
just to
Dr. Go ahead,
clarify,
Kelly.
sorry, just to clarify, Kelly Marshall for the record. So typically when we have presentations, it's either linked to a recommendation or it's general information. And we explicitly say not to a specific program because we don't want people to be advocating for funding of their program. It's about promoting evidence-based practices in the state. And so, Dr. Dixon, I'm just requesting, can you give me some coaching language about the nature of the presentation you would request so that I can accurately depict what we're asking them to present on?
Well, I think it would be related to our first topic of discussion we spent a lot of time on, related to a study. They would
The MOUD study?
Yeah.
Yeah.
Okay.
Yeah.
So, and would you be wanting their recommendations related specifically to that study?
Well, I think, well, yeah, I mean, if it's feasible, because they have the patients that you would want to be studying. So.
Yeah. So for example, just to test for clarity, so one of the things we talked about was informed consent around 3 different MOUD medications. And so we could ask them to just speak to the value of the study writ large, or it could include their opinion or recommendation related to those proposed recommendations for informed consent for recovery specialists and for adopting the principles. So those recommendations that Mr. Hamilton made and Ms. Cheatham's recommendation about conducting the study and any advice they might give us related to a retrospective study.
That sounds good.
Okay.
What I would suggest is you talk to Mr. Iverson and get his input, because he's on the board for Crossroads. And I forget what.
So would you want Mr. Iverson, who is a member of this subcommittee, to present to the subcommittee?
Well, I would be one option to ask him if he wants to, or if there's somebody else he thinks. But I mean, yeah, presumably he knows the players over there. I only know one of the nurses and the doctor, but I think, yeah, I mean, and he may want to maybe team it with somebody else, so a clinician. But anyway, I would call him and tell him we had a long talk about this, and Dr. Dixon suggested Crossroads would be somebody, a place that we would be interested in maybe being part of a study, and what is Crossroads, how is Crossroads handling this aspect of treatment of, follow-up, discharge and follow-up.
Thank you, Dr.
Yeah,
Dixon.
and any outcome data they already have, Kelly, would be helpful too. I see Dr. Kearns with her hand raised.
Thank you, Chair Shell. This is moving on to another topic. So if you're still finishing up the last one, I can wait.
Okay, we'll come right back to you, Dr. Kearns. Thank you. So Kelly, does that conclude our discussion? Do you have enough information from us at this point? Okay, wonderful. Any other comments regarding our upcoming meetings? And just to remind all of our subcommittee, as Kelly just graciously reminded us of as well, we really do need all of our subcommittee members to present at least or to submit at least one idea for a recommendation. So, okay, so moving on to item number, oh, excuse me, Dr. Kearns, before I move on to public comment, I'll turn it back to you.
Yeah, I just wanted to highlight the Southern Nevada Substance Misuse and Opioid Prevention Summit was actually held last Thursday, which was August 14th. And there were a couple of presentations that, as you all spoke, that came to mind that might assist you in dealing with the one recommendation about trauma. Dr. Amanda Habush-Deloy from UNLV Institute of Child Research and Policy, and Dr. Kristen Clements-Knoll from UNR School of Public Health did a presentation on, they call it PACEs, Positive Childhood Experiences, but they also have done a lot of work with ACEs, so they might be someone good to have come in and talk about the whole trauma and some of the research that they've already done, is the first comment. And the second comment is that I would have to find out who this group was, but I spoke to some people, and the specific ones I spoke to were community health workers. I'll have to find out what organization, but they have a program they're working on where they're bringing in med students who are going out on home visits with the community health workers to help teach this med students the holistic aspect as opposed to just looking at the person presenting them in front of them. So that might be an interesting, because I know Dr. Dixon talked about some medical education. So that might be a good program to see what they're doing and how that's going.
Great. Thank you for bringing that up, Dr. Kearns. Okay, so we will move on now to item number 8 on the agenda, which is public comment. This is for discussion only. Public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241.010. And I'll turn it back to Kelly to give us some instructions on making public comment.
All right, once again, if you're dialing in from a telephone, please dial 253-205-0468. And when prompted, the meeting ID is 89489375-298. You can press *6 and the host will prompt you to unmute for public comment. And Mr. Chair, I see that E. Scott has raised their hand.
Yes, I'll turn it over to E. Scott.
Thank you so much, Chair Schnell. My name is Beth Scott. I am for the record, I am from Nevada Medicaid. So I appreciate I appreciate the all of the recommendations that have come out of this committee, and I just wanted to highlight a couple of things for you. There was a lot of talk about peer recovery support specialist, and I know that Medicaid is in specifically about the we talked about one of the recommendations was a 3-year look back period. Medicaid is in current discussions about the qualification for peers. We are aware that there are barriers in the current MSM Chapter 100 that poses a barrier to getting peer recovery support specialists enrolled in Medicaid, and therefore their services being reimbursed through Medicaid funds. So I just wanted to highlight that for anybody who may have questions about that, provider enrollment is the department that handles or oversees MSM Chapter 100, and they may be worthy to engage in discussion about changing that policy language. I know that the behavioral health policy team has spoken with them about it, and I don't know if it's going to take an act of legislation to get it changed, as someone may have mentioned, but I just wanted to throw that out there. Also, with regards to recommendation number 3 about supporting access and linkage for treatment of trauma, I oversee substance use policy in the state of Nevada on the behavioral health benefits team, and we have supported this recommendation by allowing mental health treatment in a substance use disorder clinic. So they wanted us to really like limit, the provider type is 93 for those who speak Medicaidese, but for the providers who specifically can perform substance use treatment, they wanted us to keep it to co-occurring disorders, and Medicaid took a stance and said, no, we didn't want to eliminate access to treatment for individuals who may benefit, family members who may benefit from individuals who are struggling with substance misuse and what have you. So I just wanted to bring that to light. But there's always room for improvement. And we welcome all and any feedback that you may have as well. And when we talk about the peers in the emergency room, just to reiterate, Dr. Morgan did speak at the summit last week about the peers in the emergency room, and she did bring in the PACT Coalition, and she had a very good discussion to engage the room on that topic. And I just wanted to just highlight, there's been a lot of work in Medicaid around the crisis teams, which also includes peers. And I don't quite know how this all fits together yet. That's not I don't oversee that policy, but I would encourage anyone who's interested to go to the Medicaid website and review any of the agendas or presentations that have been presented recently or that are upcoming, as we're continuing to make strides to our policy work on peer recovery support specialist. Thank you so much.
Great. Thank you so much for being here, Ms. Scott. We really appreciate your comments, and we appreciate everything that Medicaid is doing, particularly around these topics we've discussed today. So thank you. Do you see anyone else wishing to make comment, Kelly?
I do not.
Okay. Thanks, Kelly. That will conclude public comment. Item number 9 is our adjournment. Just wanted to thank everyone for being here today, and just to remind everyone that our next subcommittee meeting will be held on September 16th. So we will look forward to seeing everyone then. And on that note, we will adjourn the meeting. Have a great day, everyone. Thank you all.
Bye.